And thanks for joining us today. I'm Ben Harris-Roxas, and I'm an associate professor at the Uni of New South Wales, and I'm joined by Dr Simone De Morgan from the University of Sydney, who's organised this webinar. Thanks for joining us today for our webinar on how can the primary care sector and health professionals help build a climate resilient and sustainable health system. So I want to acknowledge the traditional owners of the lands we're all joining from, and encourage you to add the lands that you're joining from to the chat. I'm on Darug country today, and so I want to acknowledge it always was and always will be Aboriginal land. Today's webinar has been organised by the Australasian Association for Academic Primary Care. I'm conscious that some people joining aren't familiar with AAAPC. We're a multidisciplinary representative organisation of Australia and New Zealand primary care academics who undertake teaching and research in general practice and primary care. So we have more than 180 members from places like university departments of general practice, rural health, nursing, health sciences, public health, and other settings. So, and many people who work clinically in primary care as well, or who are employed by state departments of health. So I'd like to encourage you to consider joining us if you aren't a member. Web address is aaaapc.org.au. And today's event was organised by one of our subcommittees, the Advocacy and Policy Committee, of which Simone and I are members. So we've got a really fascinating webinar, I think, about trying to come to grips with, what do we need to build a more climate resilient and sustainable health system? We've got a fantastic group of panelists for you. Mark Holmes is a registered nurse and midwife with experience from regional Australia. So Mark, you co-founded Climate Action Nurses, which we want to hear more about in a second. And that followed on from his ACN policy fellowship. Dr. George Crisp is a GP in Western Australia who's explored the concept, I think, really of a green practice within his own practice for many years now. And George is actively involved in the advocacy group Doctors for the Environment Australia, and teaches medical students in WA as well. I did want to acknowledge that Associate Professor Ying Zhang was hoping to join us, but has had a family emergency come up. Ying did a lot to help us organise today's webinar, but also her foundational research has played a really important role in Australia, in activities like the Lancet Countdown on health and climate change, to really lay the grounding for what we need to do individually and as a system. So I did want to mention that, today we're hoping to talk about some of those issues about climate resilient health systems, sustainable health systems, and decarbonisation at both patient, practice, and system levels as it relates to primary care. So there is a chat. We'll be keeping an eye on it. So please ask questions, chip in. I'll convey those to the panel as well. And I'm sure there'll be time for us to cover that before the end of the session. What I would like to do, though, is hand over to my colleague, Simone. So Simone will pose some questions for our panelists, and I'll be around and keeping an eye on the chat as well.
Thank you, Ben, and thank you to our panel members. I also wanted to acknowledge that I'm speaking to you from Gadigal country here in Sydney. So before we discuss practical ways members can respond to climate change, and people that aren't members of the AAAPC but that are here today, I thought it'd be great to hear from each of the panel members about your story, what's motivated you to become, a leader in climate resilience and sustainability. And were there any pivotal moments that you can describe to our audience? That would be great. So I think I'll go firstly to Mark and then to George.
Yeah, hello everyone, and very happy to be joining you. I'm also on Gadigal land. And my journey here today is a roundabout way. So I grew up on Wangan Jagalingou land in central Queensland, which is where the Adani mine actually is now. So I grew up in a coal mining community, and really saw the power of primary healthcare in that community growing up. The nurses and midwives in the community were the heroes and out and about in that. So I decided that I wanted to work in aeromedical retrieval, which I became a nurse and a midwife, and worked in aeromedical retrieval for 15 years or so. Worked right through the pandemic. After the pandemic, basically, I was cooked, and the clinical space had certainly taken its toll on me. And looking at where I was going next, I saw an ad for the Australian College of Nursing Policy Fellow, which I applied for and was successful to be awarded that policy fellowship for 2020. Really super interesting, because I've always been a little bit of an activist at heart and had grown into that space, but I was allocated to what was then called the emissions reduction policy chapter. And my first question was, what on earth do nurses have to do with emissions reductions? This has got absolutely nothing to do with me at all as a frontline clinician at that stage. And I went, I actually don't understand this. And I'm someone that doesn't like to not understand things. So I got quickly schooled by some amazing planetary health, or we now call planetary health, nurses and midwives, and suddenly realized that there's a large chunk of the workforce like myself that has no idea that climate change is a health issue, and that I can have some sort of impact on it. So that's when I decided that, okay, this is in one of those serendipitous moments. This is the way my career is going now, and threw everything into planetary health. Became the deputy chair of the Australian College of Nursing Planetary Health faculty. We wrote a white paper, got in front of Parliament, and really focused on that. At that stage, only 5 years or so ago, the nurses were a long way behind. Doctors for Environment's been around for probably, I think, since 2001. I'm sure George will quote me on the exact date, but 20 odd years. And being a proud nurse and midwife, I was like, hang on, we're like 60% of the workforce. So imagine if we mobilized all of those people, and that's really how I got into this space, and why I still think I'm a bit of a fraud sitting here in front of all you people today.
Thanks so much, Mark, and great to hear about your activism and advocacy with nurses. So George, over to you.
Thank you very much. Yes, so I sort of ended up doing this. It's quite accidentally, I suppose, but initially, probably 25 years ago, I first became aware of sort of climate change as an existential threat, and got really sort of fascinated by, just how much of a problem it was likely to be for us. And in my private life, of course, what often goes with that is this attempt to sort of, become more, reduce your carbon footprint. So, around the house, I was very early adopting solar panels and all these sorts of activities, and, just seeing if I could change my personal footprint. About the same time as this, I was setting up a new practice with a couple of like-minded GPs, of which Grant, I think is one. And we were really corporate refugees, because at that time in Perth, these corporates were all forming large practices, and there was a group of us who didn't really want to be corporate. We wanted to be sort of have our own little individual practice. So we got together in 2002, and one of the other doctors there, Richard Yin, was quite similar in terms of his sort of path to me. We were both doing the same things at home, and so very quickly we thought, well, why don't we do this at our practice too? We've probably got more of a chance to make a difference through our practice than we have just in our houses. And then that started us on a bit of a journey, that we realized that doing this at the practice opened up a lot of other opportunities, in as much as our engagement with the community. The practice could become a vehicle for, sort of educating our patients, or letting our patients know about climate change and environmental health, and the realization that many of the things that we were doing to try and improve the health of our environment were the same things or parallel things that we do for our patients in terms of, inactivity and transport and food nutrition and healthy food, all these things. There were these real synergies. So probably by about 2007, we'd embarked on a project we called Green Practice, and in conjunction with the school across the road, who got involved in planting, instead of a grass and picket fence, we got a food garden, and they got involved in planting and harvesting food. And the local TAFE, we got involved in a project to design a sort of a green practice website and graphics that we could use in our practice to sort of try and demonstrate what we were doing. And we thought this would be a great model because we could then sort of, get other practices to look at it and say, well, we could do this really easily. So we produced leaflets, which we used for our waiting room, and we were posters in conjunction with Doctors for the Environment to try and sort of, make this a sort of a public health exercise as well. And we got some initial interest, but it never went anywhere. No one really adopted it, and it kind of fell by the wayside. There have been several iterations along the way, trying to sort of, as time's gone by, and of course, over the years, it's become more and more apparent what the health implications of climate change and environmental degradation or ecological loss are for our health. And so the urgency and the importance has gone up, and the knowledge about those subjects too. So with each sort of passing year, we've thought that we've got more of a chance of getting people engaged. But so far, the project is still somewhat sort of underdeveloped, should we say, and increasingly expensive, of course, because websites get expensive to develop. So along that way also, I got involved in teaching, and I never intended to do that, but because of my interest in this and learning about it, I've realized, as Mark mentioned, is that very few of us actually have, we've not been taught this at medical school, so we don't really naturally know much about climate and health. And of course, if you're going to talk to people about it, if you're going to talk to your patients about it, it's really important to have a good understanding of, we wouldn't basically go and start talking to people about smoking or immunization without having a good understanding of the science and the health science, particularly behind that. So that sort of journey involved learning about, the health science behind it, but also, a lot of the climates and environmental science to support it. And that naturally sort of kind of meant that I ended up getting collared into teaching and talking to the students at the university, etc. And that's kind of how we are here. I'm still involved with Doctors for the Environment. It's been there are lots of like-minded people doing similar things around the country, sort of trying to sort of advance that teaching and advocacy around climate and health.
Thanks, George. Really interesting to hear your story. I thought I'd just open up now just a very broad question to both of you about practical strategies that the AAAPC members or other members of the audience can use in response to climate change. So you might want to focus on the patient or the practice level, or talk about advocacy that people can, healthcare professionals can be involved in, or even what is important for research and education. So it's quite broad, so please, jump in with some ideas. So I'll go to Mark first and then George, and then we'll kind of open it up a bit more to a conversation. So Mark?
Yeah, really, really interesting way. And climate change is often referred to as a wicked problem. And with wicked problems, there's a whole heap of different solutions and ways to think of it. And one of the biggest things that we find is we sometimes get paralyzed by thinking how big it is and what I can do. So what we really talk about is systems thinking and doing it from systems thinking. And systems thinking in itself, if anyone is familiar with that concept, is also a big nebulous theoretical concept. So I like to break it down about the individual, the workplace, and the organization, or wider. So individually, and George has touched on some of those individual things that we can do. So, we advocate for what we call a planetarian diet, which is cutting back those meat and dairy. It doesn't necessarily mean vegan or vegetarianism, but the research is out there that if we all stopped eating meat, we would reduce 26% of emissions pretty much overnight with that. And I say that obviously it's not going to happen overnight, but that's a big. Our food is 26% of emissions, so that's a big thing that we can do, and we can all have those individual things that we control. In the workplace, it's really interesting, and the biggest thing that I think that we can do as health professionals is educate ourselves. Secondly, educate our colleagues and our clients, patients, consumers, whoever we are working with. And it's quite hard to talk about that because traditionally, in nursing spheres, for example, we're almost taught to be apolitical. I'm also a midwife, and that's the complete flip side of the coin, is that we're taught to be political. So it's a completely different thing. So talking about it and weaving it into everyday conversations. For example, at the start of this meeting, when we had the quick meeting before the panelists, we were talking about the weather and the heat, that it's now cold in Sydney and it's hot in Perth, and that's all unseasonally things. So that's an easy way to talk with a client, a consumer, a person, to say, geez, it's hot today, or geez, it's unusually cold, or that hailstorm that was in Brisbane last night, that's abnormal to have one this year. And you can do that and ask particularly our older patients or clients, say, oh, do you remember being this hot when you were young? And you can just start to bring those conversations in. So that's really the workplace. The other thing that is low-hanging fruit for me is, particularly in primary care, you're really in control of high-waste episodes of care, and really talking about high value care versus low value care, and the extra prescribing, testing, use of all of those sorts of things. And, hand on heart, I'm a worried well, and I'm probably someone that has gone and used primary health services far too much, and had unnecessary testing and diagnostics and things like that. So that's something. And for the nurses in the practice, or those that are doing the clinical care, you're actually in charge of those high waste episodes of care. So really reducing blueies. Do you need 2 blueies? Do you need gloves? Glove use is a really interesting something. There's a lot of nursing research going on now looking at glove use, because we've just gone wild with glove use. I suppose I've been a healthcare professional for 25, 26 years now, and I still remember we just didn't use gloves for a lot of things back then. And, I went to a sustainability meeting the other day, and this beautiful young nurse stood up and said, oh, do you know that you can actually reuse and autoclave catheter kits and kidney dishes and things like that? And I went, yeah, I clearly remember doing that 25 years ago. And even there's a movement going back to using cloth drapes again and all of that sort of stuff. And I'm like, I remember in theatres when it was all cloth and reusable things. So there's some really practical things that you can do. And then moving to that organizational level or larger systems level is being that political activist, speaking with your MPs, linking it all together, driving that policy change, being at those tables, and really doing that high level, high end, blunt end system change, because that's really where a lot of this stuff happens. But that's really how you can look at it through the system. And the other thing that I would say that you can do in a workplace or in primary healthcare is your communities better than anyone else. You know where all those vulnerable people are, where everyone is and what they're doing. So on those hot days, or there's if we know we've got floods or cyclones or severe or bushfire, whatever, you can get in contact with those people. And it's very essence of primary healthcare is getting out and making sure, do you have your medications? Will you be cut off? Doing that adaptive stuff and having those conversations on the hot days. Mrs. Blogs down the road is on beta blockers and she doesn't have air conditioning at home and all of that sort of stuff. So do we check in her? Such and such with Parkinson's is going to have issues with fluids on those days. So all of that. So that's moving in the adaptation space. So there's lots of stuff that you can do out there.
Great, thanks so much, Mark. And I'm glad you highlighted how we can help those who are most vulnerable. And I think we'll pick that up in the conversation today as well. So I'll go over to George?
Thanks. Yeah, there's a couple of things you touched on. I'll definitely follow up on. One of them, I mean, is this learning about, I think it's obviously essential that the climate and health is brought into the medical school curriculum and into the college curriculums, because it touches on every aspect of the care we deliver, and in terms of keeping our practices sustainable and resilient, of course, as well. And so not having a basic understanding of that is problematic going forward. In terms of one of the things, in terms of how do we engage with this at this sort of clinical level, and how does it work? There's one of the things, and I sort of touched on this in our story, is this really sort of using these co-benefits. That many of the things that we're doing, are important for both. So if you're talking to people, if you're giving people reasons or for things to make sense, or for people to make to motivate people, knowing that there are synergies, that things can be good for you and for your community and for the environment more broadly, I think is quite a sort of a powerful message in terms of sort of arguing for change, or sort of moving people. There are a couple of other things that we learned from our exercise and today, is that in some ways it's about giving people opportunity and permission to talk about things. People may be anxious about the climate or other threats. They're not going to say something to you unless they feel that you're going to be in some ways receptive. They don't want to be judged that they might be different, particularly in the sort of partisan political climate that we live in. So it's been interesting that I think people have sought me out, or other doctors, because they think that we will understand that they're anxious about the climate. And we know from surveys that a lot of young people are anxious about this. So I think that demonstrating that in your waiting room or in your sort of public facing appearances is quite useful to give people permission to engage on subjects like that. Another group of patients who I've been fascinated by, I've got quite a few farmers, a lot of farmers in West Australia, in the wheat belt areas, also have a residence in central Perth. And it's amazing how many of them voluntarily tell me about the climate because they know that I'm interested, and they will tell me about how things have changed and why it's important. And again, I think it's an opportunity for them to sort of express that concern and that worry for them going forwards. So I think that that sort of teaching and that advocacy and how you run your practice are all involved. And I think that it's a bit of a clinical iceberg, isn't it? You don't see it until you actually start looking, and then it becomes really apparent. Mark mentioned about politics and health, and I also want to just mention that I think that health is political. This idea that you can't be political is of course not true, and we have to argue with the politicians, political parties, to get more action, because individually, of course, we're limited to what we can do, and we need politicians to understand why we're concerned, and as health professionals, why it's so important. We're the people to tell them, that we need, what we need to do with our health services to make them sustainable and resilient. And of course, it's going to be really problematic going forward in terms of how do you provide health services with increasing extreme weather events and other stressors.
Oh, that's great, George. And so, I'm interested that you sort of mentioned that connection for political and sort of collective action. I mean, what do you feel? I'd love to get Mark's perspective on this. What are some of the practical steps that we can make to work collectively to sort of amplify our influence in some of that, I guess, advocacy space, maybe more political realm of things? Just because I think that is front of mind for all of us. I know many of the people joining from previous conversations would have that front of mind. So, we can think about what hasn't worked, but what have been some of the areas of small wins, and some of the tactics and really practical things that maybe we as AAAPC members, but also just more broadly, could do. I'd be interested in your take first, George, because you were sort of steering into it, and I'll give Mark
so
think about it.
Yeah, look, it's sometimes you feel you're getting nowhere, and I think we are getting we're not going fast enough. But there clearly have been some wins and some changes, you know. And I can think of a couple of really good examples. One of them is with the West Australian example of the incoming Labour government when it was probably about 5 or 6 years ago now, is that we'd sort of talked to the opposition shadow health person about, you know, climate change and health and sustainable health. And when they got into power, they did organise a sustainable health review. Now, it may not just have been us, there may have been other people, you know, raising this as well, but they conducted a sustainable health review, and on the back of that, a sustainable health unit within the hospital. It hasn't really gone as far as we'd liked it to go, but look, it's a big move in the right direction, that it's actually there. There is a policy, there is a unit, so it's something to work on. And the other one is really looking at other groups, you know, like the AMA, a very conservative organisation who were not in the least bit interested in what we were talking about. In fact, they were, you could argue that they were very much opposed to us. I think they viewed us as a bunch of left-wing advocates or something, or activists once upon a time. But by about 2015, 2016, they started asking some of us to come in and do talks. You know, I talked to the AMA and some of the colleges over here, you know, about air pollution, about climate change and the risk for health, you know, and the AMA actually had a series of meetings from about then onwards where we sort of talked to their members about some of these effects. And now there is quite a close relationship between these groups, and they do advocate for this, and they do have a policy, you know, on climate and health. So I think that we can be effective, and that we, you know, in advocacy, you can be effective, but it often takes time, and it takes organisation, and it takes building relationships and partnerships with other groups. So I think linking, you know, groups together, you know, and time, you know, I think it just means you just need to keep working at it over time.
Yeah, and that's really good insights for us as, I guess, an advocacy committee of AAAPC, is to think about how we do need to work collectively, make those connections and act and build those relationships so that when we do speak, it's with a sort of louder collective voice, I guess. Mark, do you have any thoughts on that?
Yeah, and I think the most important thing comes down to the storytelling and the narrative, bringing it back to them, their electorates, their actual area, and as health professionals, we already have that trust. So when doctors and nurses and physios and occupational therapists and phlebotomists, and, you know, I'm not going to mention everyone, but everyone that's here, we're automatically a little bit of a authority, and it comes down to with our climate action nurses, which is interesting because climate action nurses came out because the nursing organisations were too conservative, a little bit like AMA. So we started climate action nurses so we could have a little bit more lateral movement and do a little bit more of that activist stuff. Probably not as far as Extinction Rebellion and gluing ourselves to Port Botany, for example, because we are also professionals. So we want to have a professional. So thinking about the election campaign we ran for the federal election this year, what was really successful about that is we sat down long and hard and thought about nurses, who we like, do we actually feel ethically and morally obliged to tell people who to vote for? And we had lots of robust discussions, and what we decided that what all health professionals are very good at is giving informed consent. So we went out and gave all the information and said, you vote for who you want to vote for, but be informed about it, and use those stories. And most of our members are out there working on the front lines. You know, my experience, I flew all through the Black Saturday bushfires in 2019, 2020, and did an inordinate amount of retrievals and communities in there. So my stories are a little bit old now. But there's, you know, we're having those stories. So getting those stories out and then just telling people this is what it is. crossing the divide and saying, hey, this is actually a health issue. We're not these raging greenies that want to save the whales, and like that is also very important and personally what I want to do. But bringing it over to being getting away from those climate wars, the woke wars, you know, the weaponization of the word woke, like is all of that. And the other thing that we probably learned going right back, having a look at Brexit, going right back at Brexit, and then through the rise of neo-fascism in the United States, post-truth politics, whatever you want to call it, whatever we're in now and across the globe, what we really realized is that simple messaging was actually the key. Make America great again, better off, I can't remember what the Brexit slogan was now, but very simple slogans that were really catching like that. So we're very passionate that ours are evidence-based, unlike maybe the other side of politics. It doesn't have to be evidence-based these days, but really simple things that we did. And so we also, in this last election, thought long and hard, and we did hijacking, where it was a cost of living. The election was going to be fought along cost of living lines. So we turned cost of living into a climate and health thing, looked at the evidence and really spoke to people about, you know, there's no living without the environment or with planet. So we, you know, climate costs is what we went out with, and no nurses nuclear, but the cost of living, and at first we're like, how are we going to thread this narrative through? And it actually was really easy because we just had to go to the insurance data and see anyone that lives, you know, north of the tropics are paying inordinate amounts of insurance. Those living in the central belt of Victoria are paying huge amounts, and that's all related to climate. So we went for cost of climate. And the final thing that I would say is we really need to have a localized focus, and that's where we're going now, because climate affects us all. But what's happening in my community in inner city Sydney is certainly different to what's happening to my parents in central Western Queensland, to what's happening in Perth, what's happening in the Wheat Belt, what's happening in Uluru. So we're really focusing on going to our local members, being your shire mayors or your council mayors, your state and federal, and going and saying, in my community, this is my biggest threat. So if you're in a fire-prone area, that's the biggest threat. We need to do something about that. If you're a flood area, we've really moved to that really localized, making it personal, saying, in my electorate, this is my issues, and no one knows their issues better than someone in their own electorate. So advocating for that community, and that's worked really well. Particularly in some of those marginal seats that we targeted at the election, that worked really, really well.
I think that's really interesting, Mark. And you were sort of mentioning like the bushfires and other disasters. I'm wondering whether you can reflect, and also George, on your experience like accessing primary care during those disasters, like how that could be improved. And I'm just wondering whether primary health networks could also be involved in that. So it's just thinking
do the
about
disasters give us a sort of an area where we can think about preparedness or resilience in a different way, and who could be the allies in some of that, do you think?
Yeah, 100%. It's that sitting down and doing that risk assessment for your area, getting the multidisciplinary, get the fireys, get the police, get the AMBOs, get the SES, get the lifesavers, whoever is in your area, and sit there and go, okay, in all honesty, what is the most likely natural, well, not natural disaster, what most climate disaster are we going to face in this community, and work it out? Because sometimes it's really difficult, because we just talk about natural disasters, but there's no point at this stage talking about bushfires if you're in far north Queensland, and there's no point talking about cyclones in central Victoria, for example, or all of those. So going and doing that risk assessment and working out what's the greatest thing, and then being prepared for it. So if we're cut off, if we're cut off by road, how are people going to access that? When we know we've got those early warning systems, we do a ring around in the community and make sure that such and such has their supply of insulin. We've got a great disaster checklist on our website. which we worked with the people in the south coast of New South Wales, and it talks about, have you got enough medications, wound care, continence aids, where, like, all of those practical things that you're going to think about before the situation arises. And how many days of insulin do you need? How many days of that? How many days are we most likely going to be cut off? And really thinking about and going through that disaster preparedness so that when it happens, it's not a surprise. And also for those working in clinics or those things, moving from that response phase to the recovery phase and what that looks like. Because and then, you know, following up with that debrief and thinking about, because in a community, the healthcare workers are also going to be affected by, you know, they're secondary victims of all of this, and just thinking about what those resources are out there and planning it, and then thinking about the worst case scenario, likelihood, consequence, and what you can do and how quickly we can move into that recovery phase. But it needs to be done and thought about. Having lived and worked through the Lismore floods of 2020, I can't remember, there's been so many up there, but we were evacuating whole nursing homes at the last minute, and, you know, flying in and then going on boat and transferring people on boat to planes to get them out of those nursing homes, all at the last minute. And there was no thought about that, and there was poor interagency communication. So do it before the heat of battle. And work out, you know, simply working out what the roads are. Are you in a flood zone? Are you in a fire zone? Where is the community? Where's the backup community? All of those sorts of things, because it's disaster preparedness 101.
Fantastic. George, do you have any comments about that?
Yeah, I mean, it is actually part of accreditation in general practice now for sort of disaster planning. And, you know, as Mark said, they can be quite sort of region specific or probability in region specific. It's also true that I suppose some of the disaster planning can be somewhat generic in terms of having systems in place for communication, etc. I was part of through the West Australia Health Network, a group of us had several meetings, and really it's on the back of this thing that when disasters occur, general practice is not included, you know, at any point. It's an afterthought, you know, and general practice is actually really key in terms of providing health service, particularly in the regions, you know, because they're often the doctors that work in the hospital that do everything, you know, and so you know, there has to be, you have to bring that primary care in from the beginning, you know, from the prevention, planning, you know, response and recovery, you know, not just the recovery bit. And there's been quite a few examples around Australia where that hasn't happened, you know, in bushfires, etc., that we probably know about. So I think that you know, the primary health networks are really important actually here, and they can facilitate and advance this. And, you know, as part of that sort of group, it's probably more of a scoping and steering committee, really, just looking at, well, how would it work? What would it look like? You know, how could we get it off the ground? And I know that since then there's been more happening in the regions, sort of locally with groups, you know, to try and sort of, like, you know, explore this and make. And I don't know exactly how that's progressed, but that's been a really I suppose, you know, interesting exercise. I think the other thing about disasters, you know, I think we need to be thinking, you know, at a much bigger scale, you know, level here, and particularly with politics, is that a lot of what we've done for disasters in the past are going to be overwhelmed very quickly with more extreme, more unusual. You mentioned, you know, you might not want to plan for this disaster in this location, but what we know is extremes are happening, you know, quite differently to how they used to happen. And also we're seeing these, you know, compound and cascading extremes, which means that, you know, for example, in WA last year, there was a freak weather event that blew over the power line between Kalgoorlie and Perth, followed by a period of 5-6 days of over 40 in Kalgoorlie. Now, they just managed to scrape through with a little bit of generation, you know, but that potentially, you can see how that could quite quickly unravel into a disaster. And I think we need to be thinking ahead a bit about, well, look, you know, if we're going to see more intense events, more heat waves, more floods, then how do we sort of put in place the systems and the infrastructure or whatever, to stop these things from getting completely out of control? Because it's kind of going to happen.
And that's really important, going back to having that multi-agency right at the start and thinking laterally, because we know that in a disaster, most people actually access primary healthcare first, because that's where what is physically they can actually get to in a lot of situations. And certainly having worked in emergency services and things like that, that's the lessons that we've learned, is activating all of those people well and truly before, because primary healthcare does get left out because it's not a traditional scope, as it were. But certainly in every disaster that I've responded into New South Wales, it's actually been the primary healthcare that have been taking the brunt of it. So it's going back to that system. And taking the National Climate Risk Assessment. If you don't know that, then the government came out with a National Climate Risk Assessment about 6-8 weeks ago. That actually very clearly lists all these events, and is a really, really good start to sit down and have those robust discussions in your communities with everyone, within and without health, because this is a multi-sectorial thing. Health is only going to be one sector of all of that. So thinking really laterally and thinking about bringing a whole community together is really important, and saying, oh, do we need this person? Do we need that person? I didn't think about that. Food, all of these sorts of things. And using that National Climate Risk Assessment, which is basically just a rehash of what we've been seeing in the IPCC reports for many years. But that's a good start to say, yeah, what is our likelihood and consequence of bushfires? Noting, as George said, you have to start going for those 1 in 100 year events, or those freak events, because they are no longer 1 in 100 year. So disappointed to see the Queensland government talking about 1 in 500 year events now. It's just crazy. So yeah, and it will be tested, and the frequency will increase. So we will get tired of doing it.
Thanks, Mark, for sorry, Ben. Thanks, Mark, for highlighting that they've released the National Risk Assessment at last. I'm just wondering, comments from both you and George about the role of First Nations communities. If you can share any examples of working with First Nations people to build climate resilience and sustainability, that would be great. And just the role, considering their knowledge, for climate, etc. George?
So as someone who's been working in suburban Perth, I have to say that I'm somewhat not the best person to comment on, in some ways, on this area. But what I can say is that it's quite clear that, particularly in the north of the state, there are going to be parts of the state that potentially become uninhabitable for humans outside of air conditioning, for large parts of the year in the not too distant future. And of course, there is a huge health inequality, social inequality issue arising from this, in terms of what happens to people that live there, not just living there, but also in the meantime about the loss of those or that sort of loss of habitat and normal terrain that they've been living with for a very long time. So yeah, I don't have a lot of first-hand experience, unfortunately, living in Perth. There are some. There are a couple of other issues that have come across in terms of using First Nations sort of knowledge. Here in WA, there's been an ongoing issue about fire regimes. We know basically that there are problematic fires in Perth, particularly as people have moved out into those sort of increasingly into areas where it's more bushfire prone, and the response of governments over time has been to just burn more bush, to try and sort of, just reduce the likelihood of fire. And what we haven't done, a lot of people have sort of, trying to get this to happen, is have Indigenous rangers conducting local scale burning on traditional regimes, in terms of, which are much more environmentally sustainable in terms of causing damage to biodiversity. And there are obviously real opportunities there for getting First Nations people involved in activities that are more likely to reduce risks, but also in terms of promoting environmental values as well.
Thanks, George. Mark, do you have a
Yeah,
comment?
I think the biggest thing is opening the door and having that First Nations wisdom and foregrounding that First Nations wisdom and including them in those discussions. So going back to developing the disaster preparedness is having those having First Nations people at the table is vitally important, and really suspending that white colonial fragility, because at first a lot of the First Nations approaches sound really abnormal or different to the way that we think of things. And it's just having a look at that. There's such a deep connection with land, and having just done some recent work with some policy around planetary health with some First Nations people, they just laughed at us and were like, "Oh, you white fellas are finally just caught up to what we've been doing for 65,000 years." This whole concept that that human health is dependent on the health of the ecosystem that supports it. They're like, "Yeah, duh, that's like welcome to the party." So it's definitely those things. It goes back to that local focus, is because in those First Nation communities, First Nation communities know who's vulnerable and know all the unwritten rules and law, LOIE, and all of that sort of stuff that goes on in those communities, and who can interact with who, and all of that sort of stuff. So that's really, really important. It goes back to that birthing on country philosophy, and that doesn't necessarily mean birthing physically on the country. That is ideal, but birthing on country is just that metaphor for the best start in life, and have done lots of work over the years in that space where we've listened to First Nations wisdom around birthing on country. And even in the birthing space, it's really interesting, because there's certainly some groups that I've worked with, and their mums have said, we would rather have higher mortality rates and birth on country than actually, you know, we would happy for a couple of babies to die every year versus being dragged 400, 500, 600, 700 kilometers into birth in a white person's environment. So that's really confronting for someone who comes from a position of where I don't think any mum or baby should die in childbirth. But that's really that foregrounding that wisdom and sitting there and listening and going, well, okay. And once again, that's for that particular group. That may be completely different to another mob elsewhere. So it's really that localized things and tapping into that that knowledge. And you know, we've looked at they've cared for the land. Our First Nation people have cared for the land for many, many years. You know, there's a lot of work going on in this space at the moment around First Nations wisdom. The women used to stop birthing if the conditions were bad. They would reduce the population and actively work to knowing how many humans that could be sustained on that land. So they did particular things to control that and reduce. And then when seasons were good, that's when they had babies. So that's like kind of very different to a white thing. And those things are only coming up to the surface now, if we're willing to listen to them. And it challenges me, coming from a non-First Nations frame of reference for health and wellness, and it's just sitting and listening to some of those things. So yeah, super important, but can be super difficult to sit with that white fragility and that health fragility sometimes.
Interesting. And look, I'd love to hear some queries from people online as well, if they want to chip in about things that have been on your mind or things that you've been hearing about today. One thing I was going to suggest, if it's okay, Simone, is just do either of you have any sense about what kind of knowledge or research driven, I guess, from our area of work, the primary healthcare research sort of space, do you feel might be missing, or is, you know, what are some of the priorities, I guess, for maybe research, but also education in this space, keeping in mind that many of us are coming from a primary care setting, but also that sort of research and educational approach as well. You've touched on it a lot, both of you already, but I was wondering, is there anything that you sort of wish was being done that isn't being done?
Well, one thing that I mean, I'm not sure this is exactly what the sort of research that would be done, but it often comes up, in terms of identify, or there are vulnerable groups, and how do we identify those groups? How do we put in place systems that can access or provide services or support for people who are vulnerable? Because those vulnerable groups, currently, I think with the data that we keep, we may not be very good. We might be able to identify some, but maybe not all of them. Do we do it by demographically, or do we do it by occupation, or social, other social factor specific measures, or drugs that people take? There are a number of parameters that will determine which group of people in our population are vulnerable and to which scenario they might be vulnerable. So you can see how that might become much more sophisticated in terms of how do you can't just send out a heat alert like the Bureau of Meteorology do, or go to the local hospital and say you need to enact your heatwave plan. It's got to be much more tailored, hasn't it, in a general practice sense? How do we do that? Because it sounds like a great idea, but when you actually start thinking about the specifics of it, suddenly it becomes quite problematic. And then what about the information systems that we have? And are they compromised in disasters anyway? So how do we put together, how do we do vulnerability mapping, and how do we put it into a plan to protect or enact when there is a disaster? Any ideas?
Yeah, and I don't know, does that sort of resonate with you, Mark, or what's your thoughts?
Yeah, absolutely. I mean, what I would like to know, and what I think is really important that we've missed here, is I'd love to know what the baseline climate knowledge was in the workforce, what the carbon literacy is, and what some attitudes around do our frontline clinicians, do primary healthcare clinicians even see this as a health threat? Just that baseline, because I think all I'm going to be able to achieve in my career is just talking about it and educating and getting the my aha moment, sharing that aha moment with. And I'd love to know what the baseline of. But we've been lobbying the government, Nursing Midwifery Federation, to actually do a baseline of what we think in nurses, because we get in echo chambers. I live in an echo chamber. It's a really big thing to me. I'm the converted, and I'm late to the party, but I'm converted. And then I go out and speak, and I forget, oh yeah, actually, we haven't actually had this cognitive transition in people's heads yet. So I'd love to know what the baseline is. So which then leads on to what is the education? Do people feel skilled? Do they feel comfortable talking about it? Is it too political with the rise of post-truth politics? Does it feel uncomfortable talking about political things with our clients, and all of that? So I'm doing some research in the pilot space at the moment, and I've been gobsmacked at the lack of climate literacy on the front line. So that's what I wasn't thinking, because I've been doing a lot of work in the background, the blunt end of the system, the policy, ESG, all of that sort of stuff is coming in, but I've gone and asked the front line, and I've been like, wow, okay, the mental model on the front line is completely different to the mental model in my echo chamber, and is completely different to the ESG ASX reporting thing. So I think working out what the baseline is out there. And the second thing I'd love to know is capture what's going on out there, because I know there's a whole heap of mitigation and adaptation strategies happening out there. You've got people like George fighting the system to do a green practice. We've got nurses, we've got physios, we've got all these people doing all this stuff out there in isolation. And I'd just love to do a big heat map or environmental scan and see what's going on out there, because my gut is telling me that there's lots of health professionals out there doing lots of stuff independently, and we're just not capturing it because they're taking it on as extra role. This is an extra role. This is not something that people generally do as part of their everyday. It should be. It's going to get there because the climate will affect every context of practice. We're not going to, we're all boiling frogs together. So there's not going to be a context of practice that it isn't affected. But I'd love to see what we're going out there now and do some of that mining, because I think there's all these great things going on out there with solutions that people haven't even thought of that could be easily transferable.
Mm-hmm. Now, I am conscious of time. We've managed to have a really wide-ranging discussion. I think I was really impressed with that sort of idea that both of you have touched on several times about the need to have conversations and really how do we build upon what's known, or how do we even establish what the starting point is for what our patients are thinking, what our clients, what our peers are thinking as well in practice areas. So that's going to be really important. Now, in the interest of making sure everyone can get off and either have their afternoon for George in WA, or for other people here, I'm conscious people joining from the East Coast and New Zealand will be wanting to get off and see their families for the evening. So I might try and draw things to a bit of a close. But before I do, I did just want to really acknowledge that the driving force behind today's discussion and a lot of AAAPC's action in this area has been Simone De Morgan. So thank you very much, Simone, for pulling together today and for all your work in driving this.
It's such an interesting conversation. I could keep talking to both our panelists. It's fantastic. Thank you so much for your contribution.
Yeah, and I did want to also acknowledge Katrina as well for her support in organising it from AAAPC. So I guess, I might just quickly recap, if that's all right. One of the things that came through for me was the idea of using some of our motivating experiences, our journey into this, as something we can draw on and stay connected to stay motivated, that we need to really make our personal story and journey to climate action being the base on which we draw on to connect with others, to enable us to act more collectively. And I really liked, I think it was George, your suggestion that what we're promoting as being good for our patients in terms of chronic disease prevention or psychological well-being is also often what's good for the planet itself, So I think there's a really sound basis for us to be vocal on this issue. Research and teaching can also make a really important contribution. And I think a key message that I took away was that we need to move beyond paralysis and focus on acting together. So we're going to have to do that by, making new friends, I think, and building trust with them. And maybe as researchers, we can consider also what's known about primary care and trust and localized knowledge. And if that as a setting can enable new ways of acting on climate and sustainability based on evidence. I'm going to personally include climate change in my teaching a bit more explicitly. So that's about health organizations. So drawing that link, I think, between climate change and systems thinking is going to be really important in that. And I do want to thank you all for a really thought-provoking discussion and our attendees for joining. So thanks for that. And thanks, George and Mark in particular. We've included links to climate action nurses and doctors for the Environment Australia in the chat. And I did just want to mention, don't forget to go to AAAPC.org.au, the website for this webinar when it's uploaded, and for past ones. I think the Early and Mid-Career Research Committee have got another webinar coming up, I think in only a week or two, on grant writing. So that'll be a really interesting one for people. Simone, did you have any final thoughts before we sign off?
No, I thought it was great. I guess another thing, one of the things that was highlighted to me is the importance of embedding like training into curriculum, multidisciplinary, like across the disciplines, will be so important. And many other thoughts that I've had, but I will finish off now. But thank you so much for the webinar today.
Yeah. Thanks, Mark. Thanks, George. And thanks all for joining.
Okay. Thank you.
Bye for now.
Thanks. Bye-bye.
Bye-bye. Thank you.